So I'd now like to introduce our next speaker, just as he's getting electronically equipped, who is Paul Lambert from the University of Leicester. Paul Lambert has just gained a personal chair in medical statistics at Leicester, for which we congratulate him. His work, one of his many interests has been in modelling relative survival and excess mortality, and more recently looking at parametric survival modelling. He's co-author of a recent book which he said he wasn't going to advertise, so I'll advertise it for him, which is on flexible parametric modelling survival data with applications in Stata, and that was a book I think was published in 2011. And so he's going to talk to us on this topic of parametric modelling and maybe contrast it with semi-parametric modelling as well. So over to you, Paul.
Okay, thank you. Can you hear me? Okay. So thank you, and thanks again to Daniel for organising this and inviting me. I'm delighted to be able to talk to you today. So so I'm going to talk about parametric models. So I thought I ought to start. Why do I actually use parametric models? Well, a lot of my work is with large population-based data sets, particular work within Sweden. And we frequently come across cases where the proportional hazards assumption is not appropriate, and we need to think about how to model the time dependence. And I think the hazard function is of interest. And for example, we're modeling sort of incidence of disease, which well, our time scale is age. We're modeling time since diagnosis, mortality since diagnosis, and we're looking at the mortality rate. And we're interested in how this changed as a function of time since diagnosis. In particular, I use what are called excess mortality or relative survival models, where we look at mortality in excess of that expected within the general population. And when we looked at this, there was not an easy adaptation for the Cox model. I'll talk a little bit more about this later. Again, proportional excess hazards is very rarely true within these models, and we need to model a time dependence. And again, the idea of the excess hazard rate, the excess mortality rate being of interest. For example, with certain cancers, after a certain amount of time, the excess hazard goes down to zero, and we're left with what we call population cure. The people remaining alive have the same mortality rate as you'd expect within the general population. And the other idea is that we try to think of ways of actually sort of quantifying effects within these large studies at sort of both the individual and the population level, and to do this we need absolute rates, and it's much easier if you actually have the baseline to do this. So I'm going to talk with about two slides I use when I actually teach these methods as sort of motivation. I first talk about the Cox model. Similar to Bianca, we talk about these many citations. It's slightly different for hers, I'm not exactly sure why. But one really sort of interesting index I found, this was on a blog written by someone called Bob O'Hara, it was actually 5 years ago, that this 1972 paper on its own has an H index of 13 from repeated miscitations. So what this means is people sort of want to cite the paper, they look up how someone else has cited it previously, copy that citation, and then it gets carried on. And what the H index of 13 actually means is that the 12th most common miscitation has been cited itself at least 13 times. So again, many of us may not even have an H index of 13 on our own. So I think that speaks volumes. So here's the Cox model. And again, when I teach this material, I say, well, one of the advantages, of course, one of the beautiful things about the Cox model is that we estimate our betas without having to make assumptions about the underlying hazard function. And then I go on and say, one of the disadvantages is that it's not estimated. And I think when people apply these methods, sometimes they don't think, they estimate their relative effect, their hazard ratio, and sometimes because the software doesn't spit things out, they're not, they don't really think enough about what their relative effect is actually relative to. And we're taught in epidemiology that when you estimate a relative effect, you obviously need to think about what it's relative to. And the other slide I use for motivation is from a 1994 paper where there's an interview with Sir David Cox with Nancy Reid. And so I quote from that, where Nancy Reed asks, what do you think about the cottage industry that has grown up around the Cox model? And David Cox's reply is, in the light of further results one knows since, I think I would normally want to tackle the problem parametrically. I'm not too keen on non-parametric formulations normally. And then Nancy Reed goes on to ask, so if you had a set of censored survival data today, you might rather fit a parametric model, even though there was a feeling among the medical statisticians that it wasn't quite right. And the reply is, that's right, but since then various people have shown that the answers are insensitive to the parametric formulation of the underlying distribution. And the bit I've highlighted, and if you want to do things like predict the outcome for a particular patient, it's much more convenient to do that parametrically. And this is something in our work we're particularly interested in doing. So that provides some motivation. So basically, we're thinking about sort of basically modeling the underlying hazard, or what we reduce for computational convenience sometimes is the underlying cumulative hazard function. And we either fit models on this log cumulative hazard scale or the log hazard scale. And we can either take some standard parametric form, such as a Weibull, or what we tend to do to be a little bit more flexible is use some sort of spline function, usually restricted cubic splines. If you want to use these more complex functions on the hazard scale, then you tend to either have to use sort of numerical integration, or sort of more normally, you can fit these things into Poisson regression by expanding your data set. But then we do run into some problems sometimes with some of these very large data sets. So I'll talk about the flexible parametric models, the sort of basic idea. We start with a Weibull survival curve. We transform to the log cumulative hazard scale. And on this scale, of course, it becomes a linear function of log time. So in undergraduate courses, students sometimes plot this transformed survival and try to estimate what lambda and gamma would be. And the basic idea behind the flexible parametric models is that we sort of relax this assumption of linearity by using some sort of spline function. And the function we find tends to work most easily is using restricted cubic splines. And these are sort of splines which are forced to be linear beyond, well, before the first and beyond the final knot. So what we're doing, we're modeling the underlying baseline log baseline cumulative hazard function. And of course, this is still a proportional hazards model, so our betas are still interpreted in terms of log hazard ratios. And so we have, I can stand over here, we have this spline function basically to model this log cumulative hazard function. This essentially, within the restricted splines, basically our linear predictor is made up of these two components. One part to model this the baseline, this log baseline cumulative hazard, and another part to estimate our log hazard ratios. So we estimate the effect of time and the effect of our covariates within one linear predictor. Okay. And of course, once we have the cumulative hazard, we can transform back to the survival scale, and we can also transform back to the hazard scale. Again, it's a little bit more awkward, but basically involves derivatives of these spline functions. These are, in fact, sort of fairly simple to calculate. And then once we have the survival and hazard functions, we essentially feed these into the likelihood, and we can sort of fit these models to sort of very large data sets very quickly, with no need sort of for numerical integration or time splitting. Okay. And then these ideas were sort of first discussed by Patrick Royston and Max Palmer, and they also sort of look at some sort of further link functions of the survival functions. So rather, the logit models for proportional odds models is essentially just an extension of the log logistic distribution. So on some scale, that becomes a linear function of log time. And also probit models, and that's extension of the use of the log normal distribution, which again, under a probit transformation is a linear function of time. just to talk about a bit of a simulation study, just to show you that what we estimate from these models is essentially very similar to what we get from a Cox model. We simulate data. Now, because we're using splines, we're sort of acknowledging that we're never fitting the true underlying model. We're trying to use our data to approximate what's going on. So when we simulate from in this case, a mixture Weibull model. We generate data from this. And this is quite nice. This gives us a range of sort of fairly complex shapes. Again, these are all based on some data we've come across at some stage in our research. The scenario 3 is actually fairly common in these large-scale sort of cancer studies where we have a very high mortality rate immediately after diagnosis, and then a later increase and a decrease. So we have these two turning points. And so it's a sort of shape, if we're going to use the spline function, we actually need to be able to capture at some stage. And the first of these, actually, the scenario 1, is actually just a standard Weibull distribution. So we can generate sort of data sets from this mixture Weibull distribution. This is a scenario with the two turning points. We can fit a Cox model, and we can fit one of these flexible biometric models, and we can compare the hazard ratios, and basically we get sort of essentially perfect, just about perfect enough for me, agreement between the two methods. And this goes back to the point that one is the estimates of the hazard ratios are actually fairly can be fairly insensitive to the parametric model as long as you do it well enough. But I think this is quite nice to show that on each of the 1,000 simulated data sets, the estimate of the log hazard ratio is essentially the same from the Cox model and the parametric model. We're also interested in sort of the absolute effects, and this is a comparison of what we get when we use the approximations, essentially using the spline function, of course, because we're not fitting the true model. The true model is this mixture Weibull model. And what we've looked at here is for sample sizes of 300, 3,000, and 30,000, the integrated area between the estimated survival and the true underlying survival function. And then the dashed lines are what happens if we fit the true model, this mixture Weibull model, and then we compare what we get when we fit the spline model. And of course, we need to define the number of locations of knots, which is important. But as we increase the degrees of freedom, we get closer to the truth on this scale. And even the differences up here are actually sort of fairly insignificant in terms of the way we interpret. And to demonstrate that, this is just from one simulated data set of 3,000 observations. On the left is the survival function, on the right is the hazard function. The black line is essentially the Kaplan-Meier estimate for this single simulated data. On the right, we have the hazard function. And of course, when we fit a Weibull, it doesn't fit well because the true underlying model is this mixture Weibull. Now, as we increase the number of knots, so we're putting more parameters into estimating the baseline, we start to pick up this shape where there's two turning points. And it basically, with this data, once we get to these 5 knots, or essentially 4 degrees of freedom to model modeling the baseline, we're getting pretty close. And if you watch the survival function, as we increase them, basically it changes very little, and the hazard function is also changing very little, until we get to essentially we're throwing too many parameters at the problem. We start to get some sort of local departures based on just sort of the simulated data. But even under these, you see the survival function is changing very little. In general, through the use of these restricted cubic splines and the restriction, the linearity restriction is actually quite important, and it's sort of more stable than sort of more standard cubic splines. As long as you have a reasonable number, that sort of both the hazard and survival functions are fairly insensitive to knot location. Again, remember the type of data I analyze is usually fairly large. as rough guides, we can use sort of AIC, BIC to select models. And what we usually do to convince ourselves and also other people that our conclusions are not sensitive, we present sensitivity analyses where we vary the number and locations of knots. I'll show an example of one of these later. However, I mean, I do acknowledge the sort of the way we choose these models, the way we select these models is an area where still further research is needed. Now, I mentioned that we often don't see proportional hazards, so what can we do? Well, we can introduce sort of the effects, allow the effect of covariates to be different at different points in the timescale, i.e. we have time-dependent effects. And basically, within the linear predictor, we're basically forming an interaction between the covariates we want to be time-dependent and the effect of time, which we can model using a sort of a spline function. I mean, it can be more simpler. It could be time or log time in sort of simple cases. Basically, in terms of the number of parameters, we rarely need to put as many into the time-dependent effects as into the underlying baseline, because, of course, we're modeling departures from the baseline. And you know, the most simple departure is essentially a vertical shift on the log scale. And then beyond that, it tends not to be too complex. So we can sometimes get away with sort of more simple effects. And because we're on this cumulative scale, when we have multiple time-dependent effects, things get a bit more complicated sometimes in interpretation of these time-dependent hazard ratios. And this is sometimes when you can switch back to the log hazard scale. In terms of prediction, it's not usually a problem, but in terms of sometimes sort of the interpretation becomes a little bit awkward. I'll show you an example, and this is from a large study from Sweden, basically looking at the incidence of hip fracture firstly among men diagnosed with prostate cancer, and we have a group who are treated with bilateral orchiectomy, so the removal of the testicles, and also men diagnosed with prostate cancer not treated with bilateral orchiectomy, but may have received medication which essentially changes sort of androgen levels, which may sort of have impact on their bone mineral density. And as a comparison, we can sort of select, we can compare to the general population. So we're interested in our event is having a hip fracture. We're interested in how this potentially may vary by age, and so we use age as our underlying timescale within the model. You know, this is a fairly common way within epidemiology for adjusting for age. And basically, our hazard function becomes essentially age-specific incidence rates. Here, there's actually two time scales, because there's the attained age, which is going to be very important. Hip fracture varies considerably by the age of the patient, but there's also time since diagnosis. I'm initially going to ignore that. I'll come back to that a little bit later. Okay, so we can assume proportional hazards. We can fit a Cox model and compare the rate of hip fracture among the men with prostate cancer compared to the population controls, and we see an increased risk. And we can also fit sort of the parametric model, and again, we get essentially exactly the same estimates to do 2 decimal places, and this is what happens essentially nearly all the time, because then, you know, from the results of the simulation, you would tend to expect this. So what are we actually underestimating? Well, we're estimating our underlying hazard rate. I've multiplied these by 1,000, so they become the incidence of hip fracture per 1,000 person years as a function of age, as a function of attained age. So here we're using age as our underlying timescale within the model. This is shown on the log scale, so we can see these are predictions from the model, and we can basically, our model assumes proportional hazards, so obviously our predictions do. But it turns out that these hazards are actually sort of fairly strongly non-proportional. So we can fit a model where the relative effect of being in one of the exposure groups, remember compared to the population controls, can vary as a function of our timescale. Our timescale here is age. And you can see this bigger effect among younger people. So we can actually calculate the hazard ratio, the time-dependent hazard ratio, as a function of attained age. And we can see this much larger increase amongst the younger people compared to those who are older, say over 80. So we're getting sort of 10-fold relative increase in the incidence of hip fracture. But we're still getting an increase amongst the elderly. It's not as high. But of course, this comes back to the idea of how, when we interpret relative effects, we need to understand the underlying rate within the population, within the comparator group. And of course, hip fracture is pretty rare among young people. So because we're estimating the underlying baseline hazard, we can think about, well, okay, let's, for a sort of particular covariate pattern, let's look at the differences in the underlying mortality rate. So this is the difference in incidence rate per 1,000 person years as a function of age. And of course, this goes in the other direction. So the large relative increase for these people who are sort of 50 to 60, in terms of the sort of, if you like, the extra hip fractures per 1,000 person years you would actually see is actually pretty small compared to over here, where the relative rate is lower, but of course the absolute impact is greater. And of course, you could do all this sort of thing within the semi-parametric framework. It's just a little bit more awkward. Tends not to be in sort of routine software, and certainly applied practitioners tend not to do these things so much. So I think this is a really nice example of sort of thinking about what the relative effect that means, because the association with age goes in a different direction when we sort of think in terms of the relative difference or the absolute difference. I mentioned that there's actually a sort of a multiple timescale issue here. We're interested in both attained age and time since diagnosis of prostate cancer. And we can sort of incorporate that within the model as a sort of a secondary term. And basically, we can use spline function. Now, what I've done here is I've gone back to the hazard scale. The cumulative hazard scale gets a little bit awkward here in terms of interpretation. Sort of computation is a bit more problematic. We either have to sort of do numerical integration, or we can sort of split the data finally across both timescales and use Poisson regression. Here, we've actually used sort of numerical integration. We use a package written by sort of Michael Crowder and Leicester, where it's a very nice general package where you can sort of specify sort of any functional form for your hazard, and it will sort of go away and sort of do the numerical integration for you and estimate your associated parameters. But and just to sort of talk about sort of computation, this is sort of over 400,000 observations, and even this on my rather old laptop, this takes about 15 minutes to do, and I was sort of really. It's really interesting reading the discussion about the computational issues in the 1972 paper, and I think there's a quote there. So it's one of the discussion points. It said we can even sort of fit models when we have up to sort of 200 patients with 5 covariates. And I think sometimes we forget how lucky we are to live in today's sort of computational world. Okay. In fact, the second timescale has essentially very, very little effect within this data, which is essentially why I felt safe ignoring it earlier on. The relative effect essentially doesn't change. And remember, we start this study actually starts follow-up 6 months after diagnosis. So I've talked a little bit about sort of quantification of differences. I think we looked at sort of, in our work, we often have sort of hazard ratios which are time dependent, and we try to estimate those, usually using spline functions. But we also like looking at these sort of differences in mortality rate. I think it gives us a sort of better understanding of the impact of the relative effect on disease. You can also look at differences in survival function, and there's this has relations to sort of numbers needed to treat in clinical trials. And so there's a BMJ paper by Doug Altman and I can't remember the other author, which is bad, looking at sort of calculating differences in Kaplan-Meier curves or differences in survival curves after fitting a Cox model. We can sort of generalize this to obtain these differences because we're estimating everything parametrically, getting the estimates, and also confidence intervals, sort of using the delta method, becomes fairly easy. Some of these models get quite complex. We've got these time-dependent effects. We have often differential effects by age, so we have interactions with age, and we sometimes struggle to think about how we can sort of summarize what these differences are. One and the next 2 points, avoidable deaths and loss in expectation of life, are two ways we try to use sort of understand the impact of what these differences mean at sort of both individual and sort of population levels. We try to sort of summarize these complex models in a, I guess, way in a sort of headline figure, as well as sort of presenting the details. And the avoidable deaths are sort of a what-if scenario. So this is a comparison of breast cancer survival in England and Norway. And Norway has sort of higher survival, cancer survival for most cancer sites, including breast cancer. And we have a sort of this what-if scenario. What if the UK could achieve the same cancer survival rates as Norway, and then we can go away and estimate the impact in terms of how many fewer deaths we have due to breast cancer, I'd say up to a 5-year period. And I think these sort of ways to try to sort of quantify what these differences mean are actually really important. I think when people are presented just with hazard ratios, I think sometimes people struggle to understand what it actually means, both at the sort of population and individual level. The other point I'll talk about is this idea of loss in expectation of life, which requires extrapolation of the survival curve. Some people like to extrapolate survival. This is sort of fairly common in economic evaluations. Now, what's done often is a sort of fairly standard parametric model, such as a Weibull model, is fitted, and the parameters are used for extrapolation. Our interest arose from wanting to estimate sort of what we call the loss in expectation of life associated with the diagnosis of cancer in these population-based studies. So this allows us to answer questions like how many life years are lost due to diagnosis of particular cancer, how many life years are lost due to differences in inequalities between groups, so between socioeconomic groups, or differences in survival between two different countries. However, to calculate sort of the expectation of life, we need to extrapolate the survival curve. So how can we do this in a way that we're confident will give us reliable results? So this is what we want to do. We only observe survival up to a certain point, let's say up to 10 years. We want to extrapolate this, and we have our observed survival amongst our cancer patients and the expected survival, essentially, if they were cancer-free within the general population. The loss in expectation of life is essentially just the area between these two curves. So it's essentially the difference in the two means survival for these two curves. The way we've decided to extrapolate is actually use these excess mortality models, these relative survival models. This is work by Therese Anderson, who's a PhD student in Stockholm. And what these models do, they try to partition the all-cause mortality into two components, the expected mortality and then the excess mortality associated with the diagnosis of cancer. And within these models, this excess mortality is usually modeled parametrically. The expected mortality is usually obtained from routine data, sort of published life tables, and it's treated as known. So it's like a competing risk problem, but we have one of the risks where we assume we know what the underlying mortality rate is. Just to point out, there are extensions to the Cox model for excess mortality. Peter Sacchini and Maya Perme, I think together with Rob Henderson, looked at some estimation where they treated the cause of death as a sort of a missing data problem and looked at the EM algorithm. But even with these, within the estimation process, you still actually need an estimate of the baseline. And so at each iteration, the baseline is estimated and sort of fed into the estimation process in a way. So it's not as sort of neat as the, if you like, the standard Cox model, because it still needs this estimate of baseline. We tend to fit these models on this cumulative scale, on the cumulative excess hazard scale. So this is the excess mortality model. So even though we're interested in the all-cause survival, we extrapolate through this because we can make more realistic assumptions about what will happen in the future. So we can make simple assumptions about what the excess mortality will be at future points rather than the overall mortality. And we can get the remainder from what we have from our routine data sources, this expected mortality. Now, the assumptions we can make about what happens to excess mortality, so how much higher the mortality rate compared to the general population is in the future, is that there's no excess mortality. This is what's known as population cure. And for some cancers, this is actually fairly plausible. For example, colon cancer. We can assume that the excess mortality is stabilized after a certain point in time, or we can actually estimate it from the final linear component of our model. So, for example, because we're using these restricted cubic splines, after the last knot, we assume this linear relationship with log time, and we can sort of essentially use our model to estimate that, to extrapolate. And the third one is actually the one we tend to use more fairly routinely because it tends to work in most situations. And just to show what happens, we've gone back in time. We've pretended we've got patients diagnosed up to 1970, and we look at their survival to 10 years, and then we extrapolate that. And then we can compare the extrapolated survival to what actually happened to these patients, because we obviously have follow-up information. So we're using older data as a way of assessing how well these extrapolations work. And so what we have here is the solid line of Kaplan-Meier curves, and then we have these dashed lines which extrapolated. And you can see that the extrapolation tends to work pretty well. You can see some smaller differences for this younger age group. For the younger age group, we tend to have fewer patients, and we're having to extrapolate for longer. And then some other cancers, we have breast cancer, again, pretty good extrapolations, not perfect for the younger patients. And then we have melanoma, again, pretty good, and bladder cancer. And so this, even though we're interested in this overall survival, so we can calculate essentially the expectation of life, which then leads us to estimate this loss in expectation of life. We fit these excess mortality models because we think it's more reasonable to make simple assumptions about excess mortality than the underlying mortality as the group as a whole. And these tend to work well. And what it leads us to be able to calculate is essentially sort of, first of all, expectation of life for particular individuals. So this is for a male age 65. This is the calculated expected remaining life for a man age 65 as a function of year of diagnosis. And we can see that the expected mortality, if you're cancer-free within the population, has increased from around about 14 years up to, I can't read that very well, about 18 years. So this sort of improvement in cancer survival and the expected remaining life of cancer patients has sort of fairly closely mimicked the increase among the general population. Yes. Just a final point about sort of the use of splines. I'm sure there'll be some questions about sort of choice of knots and locations, and I think this is an important area. This is just an example of a sensitivity analysis we do. This is from quite a complex model involving sort of the baseline effect, multiple time-dependent effects, and we also used continuous age, which we used splines for. So we fit a range of models. This is just a selection of those, and we can see how our fitted values vary depending on these models. And basically, in this case, you can see that basically all these models, you can't distinguish between them in terms of the fitted values. So I think this is an important thing to do. I'll skip over software. To summarize, I use the Cox model and continue to use it. However, I think certain problems are easier to tackle parametrically. In particular, the extrapolation problem. It makes sort of more sense to me to think that as a parametric problem. I think sort of quantification of the differences to different audiences, be they to patients, be they to decision makers or doctors, we need to think about. And I think to do that, we need an estimate of the underlying baseline and sort of think about novel ways to do that. I can see that most of my applications are fairly large data sets, and there are other issues with smaller data sets which need to be thought about. I should stop there. Yes. Sorry.
Paul, thank you.